Chapter 19, Sleep and Wake Disorders. We all know what sleep is, and it was a major focus of Healthy People 2030, with that key priority of increasing public knowledge of how adequate sleep and treatment of sleep disorders improves health, productivity, wellness, quality of life, and safety on the roads and in the workplace. Many of us don't get enough sleep, myself included. And for many, when there's only so many hours in the day, sleep can become expendable. Unfortunately, that sleep is very necessary for the body to function at its highest levels, and you really want to try to keep those strict sleep schedules. Major consequences of this lack of sleep is excessive sleepiness that impacts functionality and increases risk of accident and injury, and also sleep deprivation. This is that discrepancy between hours of sleep obtained and the hours of sleep required. In the short term, it can be increased stress, somatic pain, reduced quality of life, emotional distress, mood disorders, cognitive memory and performance deficits, and safety risks. In the long term, these lack of sleep can result in cardiovascular disease, weight-related issues, metabolic syndromes, type 2 diabetes, colorectal cancers, all causes of mortality, safety issues, and financial burdens. There are three types of sleep disorders. There's sleep deprivation, irregular sleep, or too much sleep. In our first case study, your sister Margot tells you, well, guess what? I've turned into an insomniac, just like Dad. I have all this stuff running through my mind, blah, 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 and I can't turn it off at bedtime. First, I have trouble getting to sleep, and then when I do, I wake up after like an hour. Then by noon the next day, I'm practically walking into walls. I'm so tired. Help me out, will you? What can I do? The normal sleep cycle. This is that non-rapid eye movement sleep. And that's 75 to 80% of your total sleep time. And stage one is the time of sleep latency, between awake and asleep. That's 2 to 5% of total sleep time. Moving on to stage two is that deeper. That occupies 45 to 55% of total sleep time and correlates with a reduced heart rate and respirations. And finally, in stage three, we have that low wave sleep or delta sleep. Further, a reduction in heart rate, respiratory rate, blood pressure in response to external stimuli for that restorative sleep. And then finally, you have REM sleep. This is 20 to 25% of your total sleep time. And this is a reduction in absence of skeletal muscle tone, bursts of rapid eye movement, myoclonic twitches of facial and limb muscles. You're dreaming. Autonomic nervous system variability, and atonia. That's a protective mechanism to present physical response to dreams. These non-REM and REM patterns, typically there is 4 to 6 cycles over each 90 to 120 minute intervals of your sleep time. In sleep architecture, this is that structural organization of non-REM and REM sleep. And finally, a hypnogram. This is a visual depiction of sleep continuity and sleep fragmentation. You may be wondering, what are sleep continuities? What is sleep fragmentation? Sleep continuity is the distribution of sleep and wakefulness across the sleep period, whereas sleep fragmentation is the number of disruptions to your sleep stages. For sleep efficiency, that's the ratio of sleep duration to time spent in bed. And finally, sleep latency, the time it takes to fall asleep. There is a complex interaction between the two processes. Homeostatic process or sleep drive to promote sleep, and then that circadian process or circadian drive to promote wakefulness and is influenced by daylight, light, and external environmental factors. Again, that sleep drives that homeostatic internal process to promote sleep, whereas circadian drives that process to promote wakefulness. In zeitgebers, exogenous factors that help set our eternal clock to a 24-hour cycle, time givers, or the master biological clock. This is located within the hypothalamus and regulates a host of functions. And finally, it helps us to meet that basal sleep requirement, or the amount of sleep necessary to feel fully awake and sustained the next day. The amount of sleep required can vary depending on the individual. Most adults require 7 to 8 hours of sleep, though some long sleepers may require more than 10 hours of sleep each night, whereas short sleepers can function effectively on fewer than 5 hours. You ask Margot how long it takes her to fall asleep at night. You are asking her about A, sleep latency, B, sleep efficiency, C, sleep continuity, or D, sleep architecture? In this case, that answer is A, sleep latency, or the time it takes to fall asleep. Sleep efficiency refers to the ratio of sleep duration to the time spent in bed. Sleep continuity is the distribution of sleep and wakefulness across the period, and structural organization of the non-REM and REM sleep is known as the sleep architecture. There are certain diagnostic tests that can be performed related to sleep, such as a polysomnography. This is an all-night test using electrodes to diagnose sleep-related disorders and nocturnal seizure issues. There's also multiple sleep latency test. This is a daytime nap that measures sleepiness in a sleep-conducive setting. There's also the maintenance of wakefulness test, used to evaluate the ability to stay awake in a situation conducive to sleep. Not to be confused with an actigraphy, which uses a tracker to record body movement over a period of time to detect sleep patterns. There can be many different disorders in this area: insomnia disorder, hypersomnolence disorder, narcolepsy, breathing-related sleep disorders, circadian rhythm disorders, and non-rapid eye movement sleep arousal disorders. There can also be conditions such as nightmare disorder, rapid eye movement sleep behavior disorder, restless leg syndrome, and substance-induced sleep disorders. This case study, predict what kinds of questions you should ask Margot to help assess what might be going on. Questions like, when did you begin having trouble with sleep? Have you had trouble with sleep in the past? Describe your pre-bedtime routine. What are activities you customarily engage in before sleep? And describe your sleep environment, among others. The first condition we'll discuss is insomnia disorder, and this is a difficulty initiating sleep, difficulty maintaining sleep, early awakening, and results in clinical distress or impairment with symptoms 3 times a week for at least 3 months. The predisposing factors to insomnia are individual factors that create a vulnerability. These may include a prior history of poor sleep quality, history of depression and anxiety, or a state of hyperarousal. Patients at risk to develop insomnia may describe themselves as light sleepers or night owls. Precipitating factors are external events that trigger this insomnia: personal and vocational difficulties, medical and psychiatric disorders, grief, and changes in role or identity. And finally, those perpetuating factors are sleep practices and attributes that maintain the sleep complaint, such as excessive caffeine or alcohol use, spending excessive amounts of time in bed or napping, and worrying about the consequences of insomnia itself. What is the most likely indication that Margot might really have insomnia? A, the difficulty occurs at least once a week. B, the difficulty occurs at least 2 nights a week. C, the difficulty occurs at least 3 nights a week. And D, the difficulty occurs at least once a month. And that answer is C. For a diagnosis of insomnia, the problem should occur at least 3 nights per week for at least 3 months. Which of the following may be a precipitating factor for Margot's insomnia? A, she never goes to bed at the same time. B, she has a history of depression and anxiety. C, she just got a divorce and moved to a new city. Or D, she drinks quite a bit of alcohol in the evenings. And that answer is going to be C. She just got a divorce and moved to a new city. The next would be hypersomnolence disorder. And this is excessive daytime sleepiness. It can be chronic, beginning in young adulthood, or excessive sleepiness impairs social and vocational functioning. And the treatment is to maintain a regular sleep-wake schedule. The next would be narcolepsy, and this is an uncontrollable need to sleep. This condition affects 0.05% of the general population, with symptoms including uncontrollable attacks of sleep, disturbed night sleep with automatic behaviors and memory lapses, cataplexy, which is a brief episode of bilateral loss of muscle tone while maintaining consciousness, hypnagogic hallucinations, and these are false auditory, visual, and tactile sensations that occur as the person transitions from wakefulness to sleep, and not rested regardless of how much sleep they get. And finally, breathing-related sleep disorders, or obstructive sleep apnea. I know we've touched on this a bit, especially in med-surg, and it's a condition that's becoming more and more common. This is a repeated episodes of upper airway collapse or obstruction while the patient is sleeping, and results in a sleep fragmentation. The patient cannot breathe and sleep at the same time. The clinical evaluation is going to have that sleep study, and the treatment is usually going to be that CPAP therapy. However, obstructive sleep apnea is not the only form of apnea. There's also central sleep apnea, which is the cessation of breathing during sleep. It's an instability of the respiratory control system, and it's related to aging, advanced cardiac or pulmonary disease, or neurologic disorders. There's also sleep-related hypoventilation. This is sustained oxygen desaturation in sleep with no apnea or respiratory events. Circadian sleep disorders are the misalignment of normal circadian rhythm timing and external factors affecting the timing or duration of sleep. These types are such as delayed sleep phase, advanced sleep phase, irregular sleep-wake, non-24-hour sleep cycle, 70% of cases occurring in blind individuals, and shift work as well. When you get your first nursing job or begin on a rotating shift, it's going to be a real priority, real difficult for you to get in that habit of maintaining a proper sleep schedule based on your work schedule. Non-rapid eye movement sleep or arousal disorders such as sleepwalking, sleep terrors, nightmare disorders, REM sleep behavior disorder, which is that elaborate motor activity while daydreaming, restless leg syndrome, and substance-induced sleep disorders. Next question, which of the following is a treatment for upper airway collapse and obstruction? And that answer is, as we've discussed previously a few times, is a CPAP machine. To really hold that airway open, give it that positive airway pressure. There's many other conditions. It can be a comorbidity with these as well. Alzheimer's, Parkinson's, psychiatric disorders such as bipolar, manic phases, increased risk for suicidal ideation. That short sleep duration is often associated with obesity, cardiovascular disease, hypertension, impaired glucose tolerance, and diabetes, and mood disturbances. And unfortunately, these short sleep durations and lack of sleep places the patient at further risk for hypertension, diabetes, cardiovascular diseases, and even stroke. For their assessment, you're going to be looking at sleep patterns, having the patient make a 2-week sleep diary, identifying sleep-wake disorders, and other indexes and assessment tools such as the Pittsburgh Sleep Quality Index or the Epworth Sleepiness Scale. We want to focus our health promotion on the patient's sleep hygiene, limiting overtime, limiting shift work to 8 hours, and obtaining 7 to 8 hours of sleep within a 24-hour period. There's going to be many different nursing diagnoses we could use here. Insomnia, hypersomnia, sleep deprivation, risk for impaired sleep, nightmares, sleepwalking, or apnea. Classification outcomes for insomnia, we want to focus on improving their sleep. That successful sleep induction, making sure they're getting the appropriate hours of sleep, having a consistent sleep pattern, and minimize awakening throughout the night. We also want to prevent sleep deprivation. Again, getting that balance between work and sleep, minimizing awaking throughout the night, and feeling restored after sleep. And impaired sleep. This is an adequate quantity and quality of sleep with minimal awakening and feeling restored. For planning, it's a multifaceted approach with occupational considerations, social, interpersonal, and medical considerations as well. And it's really going to be a team approach under a sleep disorder specialist. And the nurse's role is going to be assessment, support, patient education. We want to counter the hopelessness with encouragement. Give them that health promotion and teaching that they need. Teach them how and the reasoning for a sleep diary. And working on that sleep restriction technique. Once sleep efficiency is improved, the total sleep time is gradually increased by 10 to 20 minute increments. That evaluation is further based on whether the patient experiences improved sleep quality. It's evidenced by decreased sleep latency, fewer nighttime awakenings, shorter time to get back to sleep after awakenings, and the improvement in daytime symptoms of sleepiness. This is accomplished through patient report and patient maintenance of a sleep diary. Audience response question. What is the minimum amount of sleep a nurse on shift work should get in a 24-hour period? That'd be 4 to 5 hours, 5 to 6, 6 to 7, or 7 to 8 hours. And that answer is D, 7 to 8 hours. In severe cases, pharmacotherapy may be used. But again, medications is usually discouraged because non-pharmacologic treatments have shown superior efficacy in reducing insomnia. We want to really identify the underlying cause here and use medication as the last resort. And for our last question here, as part of Margot's stimulus control to counteract her insomnia, she should not A. Skip the prescribed daily nap, B. Get out of bed if she can't sleep, C. Limit bedtime to when she's actually sleepy, or D. Read in bed to help her relax and get sleepy. And that answer is D. Reading in bed is not a good idea if you already have trouble getting to sleep. Contrary to popular opinion, the 5 principles to reduce negative associations between bed and the bedroom and for strengthening that stimulus to sleep include: only go to bed when sleepy, use the bed or bedroom only for sleep, no television, reading, or other activities in the bedroom, get out of bed if unable to sleep, and engage in a quiet time activity such as reading or crossword puzzles. Maintain a regular sleep-wake schedule and avoid daytime napping. That napping is absolutely necessary to avoid. It should be limited to 20-30 minutes tops in order to help maintain that circadian rhythm. Anyway, that's the last slide we have for this chapter. There's a lot of people out there who aren't getting enough sleep. I've had the same issue. I was night shift nurse for a long time and a night shift paramedic before that. And especially those first few years after going from night shift work to getting on a day shift schedule was extremely hard. I could get back to a night shift schedule really easy, but getting on that day shift schedule, and it really can wear you down. Especially if you're getting that first nursing job and you're on a rotating schedule, you really want to make taking care of yourself and making sure you're getting enough sleep and setting yourself up for success to get enough sleep. It'll go a long way to improving both your functioning as a nurse as well as your quality of life. But anyway, that's all we've got for this chapter. I'll see you in the next slides.